I'm Associate Professor Rob Selensky. I'm a medical oncologist practicing here in Orange, New South Wales on Wiradjuri lands. I'm a multi-tumour stream medical oncologist, so I treat brain cancers, but I also treat 5 or 6 other types of cancers. So in the Western New South Wales Health District, we've never had a truly focused subspecialty care model for brain cancer patients. And that's clearly something that's necessary to improve outcomes. Currently, we have medical oncologists like myself who treat brain cancer patients, but also treat melanoma, lung, prostate. And given the complexity of all of these tumours and the advances in the scientific discoveries, it's very challenging for us to stay at the absolute pinnacle of our knowledge for all these tumours. We are blessed though with radiation oncology services that visit us from Sydney, and we have subspecialist radiation oncologists who treat gliomas. Prior to this development, we had general radiation oncologists treating all cancers, and I've certainly noticed a very big shift in delivery of radiotherapy and in total care of the patient with this model. All of the surgery that's necessary for brain tumours is performed in Sydney. It's not performed out here in the region, and rightly so. So there's a lot of travel involved in the initial diagnosis of a brain cancer for our patients. We've also only had general care coordinators to look after brain cancer patients along with all the other types of cancer patients. And so that's our care coordination service at the moment.
In Western New South Wales Local Health District, we have 2 radiation oncology departments, so one in Orange and one here in Dubbo, and we have 3 linear accelerators over those sites. So we're able to treat most brain cancers that are eligible and suitable for radiotherapy. We do a program called SRS, so that's stereotactic radiation therapy or radiation surgery, and that's a very advanced world-class approach to treatment, and small lesions can be treated with radiation. So it's really amazing to be able to do that in a regional rural area, and a great opportunity for patients to not have to travel away and have that level of care. Professor Michael Back, is the radiation oncologist that oversees that delivery of care, and it works to such a world-class level because he's able to do that as a VMO, and often he doesn't need to be here. We have the technology that Professor Back can be in Sydney, and he can video health into those patients and meet them and do consultations. He's able to do the radiotherapy planning and voluming and telling us as radiation therapists what he wants from Sydney. So that model and the technology is amazing to be able to deliver that world-class care.
I think, however, there are some issues with access to allied health services, and where we really fall short, even though we're able to provide world-class standard of care from a medical perspective, we're not really able to provide adequately resourced brain psychology, brain occupational therapy and brain physiotherapy, because there's difficulties in attracting people and difficulties retaining them once we do.
I think the biggest challenge has been for me personally being able to be across all of the nuanced developments in the systemic therapy of gliomas. Given that I'm a multi-stream medical oncologist, which is common across all the regions of Australia, it is incredibly challenging to stay abreast of what exactly is happening in every single tumour stream and where we should be looking or pushing the patient. Guidelines are very, very successful, and they help coordinate standardised care, but what patients want are clinicians that are looking for niche opportunities, areas where they could be treated a little bit differently. Clinical trials is a big example of that area that I'm talking about. We've never had a clinical trial for brain cancer patients in our district. However, we've had innumerable trials for other cancers. So there's a big challenge and a big discrepancy in getting access to clinical trials. And I regularly get asked by my brain cancer patients, are there any trials? And indeed they are, and they're all in Sydney. And so again, there's a huge travel dislocation both to them and their carers, because more than a lot of the tumour streams that I treat, they really do rely on carers, because there's often a lot of cognitive impacts, mobility, vision, which we don't see in other cancers as much. So a big challenge is access to clinical trials. A big challenge is being able to sort of rightly say that you are a neuro-oncologist, and most of the world leading places would have neuro-oncology as a discipline. And I think the lack of a navigation care coordinator dedicated to brain tumour patients is clearly a huge challenge. Again, we've got care coordinators who look after lots of different types of cancer patients who all have slightly common but also unique needs as well.
The biggest challenge we have is workforce. So attracting and retaining staff in regional areas is very difficult. The state government are very good as far as offering incentives and things for people to come and work in regional areas. And at the moment we do have good radiation therapy capacity with staffing, but we do care coordination, nursing, allied health, all the extra services that are required to give it the best patient-centred care and holistic care are fairly lean in the regional model.
So, as with all rural and regional sites, there's a gradient in terms of how rural you live and how much toxicity you have. And it's not just usual toxicity that we think of with chemotherapy, but it's time toxicity, it's financial toxicity. And I don't think that's discussed enough. Really, if we're trying to do best standard of care, would be able to provide people with navigation to services and adequately provide those services closer to home so that people are able to access them. And another gap that we certainly see in rural areas is access to clinical trials. Large pharmaceutical companies don't like investing in clinical trials in rural areas because we don't recruit as well, because the centres are smaller. If we're going to be able to provide world standard care in rural areas, there need to be incentives for large pharmaceutical companies to provide clinical trials in rural sites.
Yeah, I mean, so there'd be great services that we could provide. Things like having sort of a dedicated neuro-oncological nurse. That would go great with helping manage their care. As I said previously, it's quite an advanced sort of care in terms of their surgery, and everything's quite protracted and sort of across different regions. So managing that care is one of the harder parts to go with. And I think it's quite essential care with cancer care services. Yeah.
Navigation, I think, is probably one of the big benefits that we could address, ensuring that things are sorted for patients to be able to get to Sydney, accommodation for them to stay, and then transfer of care, making sure that we get effective communication from those centres, and then that they're getting on treatment in a timely manner as well. That referrals are coming through appropriately. There's no gaps or misses in those systems. And in large, we are doing that at the moment. But I think could always be improvements in the way that happens.
My name is Scott Brown. I'm 53 years of age and I have stage 4 brain cancer. To be honest, the hardest part was coming home. Was leaving the hospital in Sydney, and was to come home and having that from leaving hospital to the time the first talk to our professor is where I found it the most difficult. It was the most depressing, saddest part that I found. It wasn't until I was able to physically talk to someone and to meet the team that was going to look after me and help me that that things started to improve, that I started to feel better about myself. Would be probably the biggest thing would to be have that person that you could talk to within a couple of days of after having your treatment and everything like that. I was lucky in having, when I did my all my radiation treatment, I had 30 shots of radiation, and to have a nurse that regularly contacted me once I'd finished that, every 3 days was nice. They would sit down for those 10, 15 minutes or whatever and talk to about it and things like that. And that lasted for a couple of weeks, and then that was their next stage. They said, we have to give this up now and move on to another stage. And after that period, you had really no one to talk to. Like, you had your family, but it's not like having someone that that's class is independent, if you want to call it that way. Someone that you can sit down and have a really good nice chat and discuss, little problems that you're facing, you seem to be facing. You don't want to keep taking this back to your family all the time and feeling bad about, so.
Yes, I'm Gavin Smith. I'm a resident in the Bathurst area, and I'm 68 years of age. And I was recently diagnosed with a tumour. Well, there was really nobody I could turn to for like face-to-face information straight away. I actually received a lot of information when my daughters researched things online, and I really missed not having someone to talk to when I was first diagnosed, because I just didn't know, what to expect or what was going to happen. And that was a difficult time. I did notice when I had surgery in Sydney, there was a lot of people were in supporting roles down there, and I noticed that there's probably just not the numbers here to support people in the regional areas. I just noticed that straight away. Yes, we have to travel, for treatment we have to travel 150 kilometres every day. So it puts a little bit of extra strain on the family, the other family members, because they've got to make allowances for us leaving early and all the rest of it.
Hi, my name is Sharon Brown. My husband Scott Brown was diagnosed with a glioblastoma in March 2024. We've been married for 31 years. He was diagnosed the day after our 30th wedding anniversary. From then he was flown to Sydney, and that week he was operated on, had a part of his brain removed. Obviously the initial diagnosis is very traumatic to hear that your husband of 30 years, has terminal brain cancer. It's news that no one wants to hear. Obviously we have 2 adult daughters. They were there when we got the diagnosis, so as a family I'm just glad we were all there together. But coming home, obviously it's a lot to wrap your head around, to try and make a plan of how to move forward. It was a bit of a struggle because you're trying to, obviously get your head around it emotionally, but then also too at the same time, you still have to live a life somehow, deal with work, deal with your family. We're pretty lucky with the Western Cancer Centre. If we didn't have this here in Dubbo, it would definitely be a lot more difficult having to go to Orange or possibly Sydney for Scott to have treatment. So we are lucky in that respect. However, I feel like we need more services here, especially when it comes to like that higher end doctor, like a neurologist. We were having to travel to Orange when Scott first started having symptoms a few years ago. So that's a 2-hour drive for us. Obviously that impacts your work when you're trying to work. Scott would often be working remotely, so to make that plan, it wasn't just a simple thing like you could just take a few hours out of your day. It was a full day thing. Also, once Scott started treatment, his radiation oncologist flies in from Sydney.
Hi, I'm Esther Beshman, and I am a carer to my husband Scott, who has glioblastoma, which is stage 4 brain cancer. I'm a mum to 2 little people as well, so 2 and 5, so trying to manage the needs of little people, plus also being a carer for my husband, I've found really, really hard trying to make sure everyone's needs are met. And I'd also say in terms of the psychological impacts and the changes that I've noticed, the depression, the desperation, that emotional toll that has on someone of a younger age, I think isn't spoken about enough, in terms of when you've got a 35-year-old male facing his mortality instead of thinking about the beautiful little kids that he's going to see grow up. No one can prepare you for that, and I think being the carer for that person, you're their emotional ambassador, and you've got to try and carry them, but you're also trying to carry your own weight and your own pain through that. So I think psychological support could go a long way in helping people with brain cancer in particular. We now have accessed a neurologist in Sydney, and we do telehealth appointments. But I really miss that genuine face-to-face connection that you can build with your medical team. You've really got to trust these people, and it'd be really lovely if you could actually sit down face-to-face. But due to where we live, you're dealing with the isolation and then trying to communicate through a video, like a TV, a laptop screen. It's really challenging. Same with Michael Back, our radiologist, beautiful man. Have had many conversations through telehealth and through email, but I've never met him in person. But yet he's been a vital part of my husband's care, but I haven't had the privilege of meeting him. And so I think building relationships is what people really value in this process, because it takes such an emotional toll on you.
I think it's many things, but a lot of it is awareness. I think we have a good model where we have expertise from metropolitan sites working as subspecialists, supporting our delivery of care and our decision making. And then we have a local team who are able to deliver that world-class care. And I think that really does bridge the gap between metropolitan and rural. However, it's that ongoing workforce that we really need to keep a focus on, to make sure that we have the support roles, the allied health roles, the care coordination roles, and they're often a bit leaner in a regional model because we don't have the high number of patients to actually be able to demonstrate the need for all of those roles.
Bridging the gap, to me, looks like providing adequate allied health resourcing in addition to the medical resourcing that we've seen locally. That's not just in physiotherapy, psychology, occupational therapy, but also things like nurse navigators, cancer navigators within communities, Indigenous navigators within local communities, to help to bridge that gap and to make it seem less alien that people have to travel to the big smoke here in Dubbo from the community that they live, which may be hundreds of kilometres away. Bridging the gap doesn't just mean providing world-class medical care, it means providing care across the spectrum in all allied health, psychology and nursing domains.
I think the space inside a carer's head gets really overwhelmed and overstimulated, and I really feel like if you could have a central person, like a key contact that you could go to that has a checklist that could help you work through all the things that you need to navigate in terms of organisations like Can Assist that can help, the Cancer Council, doing the NDIS application, all of those things to help navigate and to keep you somewhat accountable, to say, oh, like, how did you go making that appointment and following up on that? Because I do think there's some wonderful services, but unless you don't know to call, or you get really busy in the running to the chemist to fill the script or going to all the medical appointments, that all those other things that really matter, I think you just forget to do. And so having a key contact, someone you could refer to help with that process, I think would be really helpful. I do find that there's a big gap between New South Wales Health and NDIS. NDIS seem to not want to assist with end-of-life preparation. They say that that's a responsibility of New South Wales Health. However, in our experience, and for my husband who has probably less than 6 months to live, New South Wales Health asked the question, are they an NDIS participant? And if you answer yes, then that's where the draw is. That's when the line's drawn, and then they say refer to NDIS, and then you refer to NDIS and they refer you back to New South Wales Health. At the end of the day, families just want to be as prepared as they can be about preparing for death and what that looks like. And I think, it should just be about the support rather than the person delivering it.
I probably would ask for a bit of equality between the metropolitan and regional areas. There's just not the support in the regional areas compared to the metropolitan areas. From what I saw, of my experience with the hospital in Sydney.
Please, when you make these decisions in Parliament, think of people in the bush. We count too. And there's a lot of us out here. You don't realise how many people rely on the services in Dubbo. It's not just us in Dubbo or the closest towns, like people in Burke and Broken Hill and all those places, they rely on Dubbo. So the more full-time services we can have here definitely gives people more options.
So if you're listening to this and you have the ability to help rural patients with brain cancer, my plea to you would be, we need to set up almost network centres of care where all rural regional brain cancer patients are connected to a neuro-oncology dedicated service. I don't think these patients should be left out in the country with services that are just not appropriate for this day and age. And by that I mean, having access to all the latest research, evidence and technologies to help manage their tumours. So please help us, and let's work together to increase research. There clearly needs to be far more clinical trials in brain tumours, and let's work together to bridge the gaps that we've identified. Thank you.